Well, the first thing is to say hi to everyone. We are very happy you are all here. For the ones who don't know, this is the interest group of the SPR focused on child, adolescent, and family therapy research. We do different activities like these journal clubs, seminars, webinars, and we try to get together the ones that are interested in this area of psychotherapy research. So for the ones that are not in the list, you can go to the webpage of SPR, to the interest group, and then you can see child and family therapy research, and there is how to join the group. So we're going to start this journal club about trauma, parenting, and the therapeutic relationship with parents in child therapy. We are very interested as we all work with children and adolescents. We know that working with parents is an important and relevant aspect of child therapy. However, we know that we don't have much research on this topic. So the idea of this journal club is discussing working with parents and specifically about the therapeutic relationship with parents in child therapy. And we want to discuss a specific topic related with that is trauma and parenting, and how trauma in parents can affect the therapeutic relationship in child therapy. So we have today, first will be Nicolás Gabriel-Vache. He will present a paper on this topic. He's a PhD student at the University of Chile, and his research project is related with the role of the adverse childhood experience of caregivers in child therapy. And then we will have the discussion from Dr. Michelle Sleed. She is the Deputy Program Director of the Doctorate in Child and Adolescent Psychotherapy and Senior Research Fellow of the Child Attachment and Psychological Therapies Research Unit at the Anna Freud Center, London, UK. After we have the presentation of Nicolás and the comments of Dr. Sleed, we will have some time for questions or comments from the audience. So now I will leave Nicolás so he can start his presentation.
Thank you. I will begin sharing my screen. Perfect. Can you give me a thumbs up if you can? Perfect. So, well, good morning, good afternoon to everybody. As Claudia introduced myself, I'm Nicolás Gabriel-Vache. I'm a psychologist. I'm a PhD student at Universidad de Chile. And today I will be presenting our paper, The Adverse Childhood Experiences of Caregivers of Children who have been victims of sexual assault, and the relationship with the Parental Alliance in child psychotherapy. The data of this paper belongs to a larger research named Process of Psychotherapeutic Change in Children who have been victims of sexual assault towards a comprehensive model of the influence of factors of caregivers, interventions, and the therapeutic relationship. And today we will be addressing especially these two topics, caregivers and therapeutic relationship. The principal investigator is Claudia Capella, our chair of this meeting, and it's a mixed methods study. Today we will be presenting quantitative results. It's in a Chilean context. It started in 2020, and we pretend to finish in 2024. And as we said before, in this meeting, we will be presenting the results of this paper. I hope you all received it in your emails accounts. If not, you can write to us My email will be in the final slide. And I will be addressing some of the background, the methodology we use, the main results, and we will take more time in the discussion. How do we interpret these results? So first, I would like us to address what do we mean with adverse childhood experiences? What are we researching in these caregivers? Well, first of all, ACEs are potentially traumatic experiences that occur before the age of 18. And research have found that there's a dose-response curve, meaning that the more ACEs a person have experiences in the first 18 years of their life, there's a greater risk of pathways of mental health problem, physical health problems, and recent studies have shown that also is associated with parenting difficulties. We have studies in Chile that shows a higher prevalence of ACEs in our population. Here in the first point, we see that there's a worldwide prevalence of 38%, and in Chile, latest study of the last year shows 68% of adults have experienced, at least in Chile, one childhood experiences. Now, one type of ACEs is child sexual abuse. That's the topic we are researching here in this longitudinal study. Children has been sexually abused. So let's talk a little about that. First, there's a world prevalence of almost 12%. But again, in Chile, we have a high prevalence. A study of the latest years, we have shown that 26% of youth have reported one or more sexual victimizations in their lifetimes. As with ACEs, also there's a risk associated with this child sexual abuse, but a little of hope is that psychotherapy has shown to be effective for the consequences of the child sexual abuse. And in Chile, we have the PRMs that could be like repair programs for the maltreatment and child sexual abuse as our largest public programmatic offer. And children in these programs receive psychotherapy on the one hand, and the caregivers receive support and interventions from social workers, but only focused on their protective skills in their caregivings. So in this presentation, we will show, or our aim is to pretend to show how different aspects of these caregivers are also relevant in this therapy. So now I would like us to think in two trajectories. First, we will focus on the caregiver ACEs. And research have shown that caregivers that have experiences different kinds of trauma, like not only child sexual abuse, but maltreatment, emotional neglect, and different kind of violences that can happen in their households, can affect in three levels. First, on their own mental health as a caregiver. On the second level, on the mental health of their children. And in a third level, on their parenting practices. Also, if we remember this dose-response curve of experiences, ACEs, adverse childhood experiences, and the more number of ACEs can affect also in the parental involvement and support they offer to their children, and a greater pre-mentalizing reflective function, meaning the way they are imagining, they are minding the inner world of the children also gets affected by their traumatic experiences. So, as I said before, we could be thinking in two trajectories: the parenting trauma, and in this second level, this second trajectory, the child's trauma. Now it's when they collide, you could say, when the children in our sample experiences the child sexual abuse. Research positions these caregivers as indirect victims of the child's sexual abuse, meaning there's a double crisis on them as a caregiver. On the one hand, on their parental role, with all of the doubts they are thinking and feeling of how they failed by protecting their child and how they were exposed to this kind of violence. And on the second hand, the risk trajectories of PTSD symptoms, depression, and anxiety they begin to feel and experience. And also, these kind of studies have reported the significance, like role that they can have in the treatment, meaning that not only the child should receive the treatment, but also they should be included once the child's sexual abuse has been stopped and therapy can begin. And finally, after these two pathways collide, we think what happens next. And first, there's a glimpse of hope, as I would say, because research shows that caregivers with a high reflective function of the trauma, meaning how they could reflect, think about this experience, its consequence, the emotions, and the consequence of what they experience in the youth can affect their life as an adult and as a caregiver, is associated with a lower probability of child sexual abuse in their children. But also we have studies that have shown that the intergenerationality of the child sexual abuse can be a barrier to the treatment engagement of their child's, of what their sons and daughters have experienced, meaning that their history of trauma can be affecting how they are engaged in what their children now have experienced. So we discussed a little about ACEs. We discussed a little about the effects of the child sexual abuse on them as a caregiver. So let's talk about the thing that summons us in this presentation, the Therapeutic Alliance. On the one hand, the definition we used is the one of Bourdieu, the one that contains three different and interrelated dimensions: the agreement in the goals, in the tasks of the therapy, and also the therapeutic bond that develops in this setting. And when we think in child psychotherapy, we are also thinking in different levels of relationships, right? Between the different people. At the difference with the adult therapy, we have at least three different participants: the child, the caregiver or caregivers, and the therapist. And what research has shown is that this kind of variable, the therapeutic alliance in child psychotherapy with the caregivers, can predict a better alliance, a better outcome. And what we discuss in this paper is especially the initial phase that encompasses the first sessions, that makes it possible to attain satisfactory levels of trust. But on the next slide, we will discuss how this trust can be affected by the trauma that a person can experience. So let's talk about trauma and therapeutic alliance. What research says is first that exploring the traumatic memories may damage this alliance. So let's think a little about the settings that we're investigating, researching. We have caregivers with their trauma stories, potentially with their trauma stories, and we have these children who have been victims of child sexual abuse. So exploring these traumatic memories in the caregivers may cause iatrogenic harm, or including increasing client dropout of the therapy, and may damage the alliance. Also, literature have shown that trauma can cause avoidance, emotion regulation problems, and mistrust. And in the previous slide, we've seen the importance of the initial sessions to build this trust. But a little of hope too is that a recent meta-analysis showed that even in trauma cases, a good alliance predicts better outcome in PTSD symptoms. So, with all of this in mind, ACEs, Therapeutic Alliance, and the impact of the child sexual abuse of their children in the caregivers, we're always thinking in these two trajectories, and we present them this research question. What is the relationship between caregivers' adverse childhood experiences, post-traumatic symptomatology after their children's abuse event, and the Therapeutic Alliance with the child's psychologist? As for the methods, we had a sample of 58 caregivers of children in CSA psychotherapy. The children were aged 4 to 9 years old, and we included the reports of the children's psychotherapist. For the measures, we used 3 different instruments. First, the CDQ for measuring the caregiver adverse childhood experiences. We used the ITQ for PTSD symptoms in the caregivers, and we used the TASC, which is a parent-caregiver therapist alliance measure. This data, the ones that we presented in this paper, belongs to the first measure of this ongoing longitudinal study. These measures were primarily gathered through online meetings because of the COVID-19. Now we're gathering data in the centers, and the analyses were descriptive, correlationals, and moderation. So let's see the results. First of all, we found that the caregivers valued higher quality of therapeutic alliance compared to a psychologist, if we can see in here. Then we observed a high number of caregivers presented symptomatology of PTSD after this event occurs to their children. So let's go back to how they are receiving treatment, only focus on their protective skills. Well, we can see that they are living a difficult moment. So this is for discussion, but this is very interesting of how they are also suffering what their children is suffering. And according to their ACEs, their childhood adverse experiences, more than half of them have experienced ACEs. And if we look deeper into them, almost 26% of them reported 3 or more adverse childhood experiences. Let's go back to the research literature. Remember this dose response. The higher the ACEs, the higher the risk trajectories they could be experiences. Well, there's an accumulation of experiences in these caregivers. And 33%, almost 33%, have experienced child sexual abuse. So there's intergenerationality here also. If we look to the correlations, we observe that the higher the ACEs, the lower the therapeutic alliance. And what is interesting is the difference between who reports the therapeutic alliance. For example, on the one hand, caregiver reports emotional and physical neglect here correlates with lower alliance, and on the other hand, psychologists report that the higher the total experience of the caregivers, emotional abuse that the caregiver experienced, and physical neglect correlates with a lower alliance. As for positive correlations, we observed between adverse childhood experiences of the caregivers and their post-traumatic symptomatology. The greater the trauma they experienced, the greater the symptoms they are living after their children have been sexually abused. And finally, we ran a moderation analysis. This allowed us as a team to test the influence of a third variable, because previously we were discussing these correlations. So we can explore how one variable affects other two. We tested how PTSD symptoms here with ITQ total, remember this was how we measured PTSD symptoms, influences the relationship between the parents' adverse childhood experiences, their trauma, and the task. Remember, it's what we used to explore the Therapeutic Alliance. So how these symptoms influences the relationship between these two. And what we found is that caregivers who reported high ACEs here and less symptoms, this is what was statistically significant, presented a lower quality of the task of the Therapeutic Alliance. So, again, because this can be difficult, parents with high trauma, but with low symptomatology of PTSD showed a less or a worse Therapeutic Alliance. And this was a surprise for us, so we will be discussing that now. So let's speak a little about our results. What sense do we make of them? First, I would like to think in what here in the title says, the lens on the caregivers' pathways. We observed in the results a high prevalence of ACEs and symptoms in the caregivers. And we also observed how the relationship between them. We also know that these families receive psychotherapy for the children here and social support on their protective skills, how they can prevent a new exposure of child sexual abuse to the children. But also we know with these results that the caregivers are experiencing difficulties too, symptoms, they have their own trauma stories, and they have their own possible problematic trust aspects in developing a alliance with a therapist. So we think in the importance of trauma-informed care or trauma-informed systems, which have different levels. First is the level of realizing that trauma has a widespread effect. And we know these professionals know that. They work with child sexual abuse, they work with trauma. But what's interesting is in this mixed methods study is that on the one hand, we have these quantitative results, but we have also interviews with the social workers, the psychotherapists, the caregivers, and the children. And what the professionals have sent to us is that there's a glimpse of that. They know that these caregivers have suffered a lot, but they don't have tools for screening, or they have not implemented resources for tracking, assessing their symptoms and their trauma stories. They are mainly focused on the children. So more effort could be put into this second level of recognizing the signs and effects. A second thing we think it's important is what happens with these two pathways collide, the trauma of the parents here and the sexual abuse of the children. And that's what I propose in this title, is that again is too many times. It seems that these parents with high traumatic backgrounds, but that did not report symptoms and had lower alliance with the psychologist, we explain ourselves these results as these parents showing dissociative defenses that are operating to defend themselves from this experience. That's why, again, it's too many times. I was abused in these caregivers. Their experience is that I was abused. Now my children was abused. This is too much for me. I disconnect from the symptoms that I'm feeling, and I put a barrier on how I am presenting and developing this relationship with the therapist. That's how we try to explain these results to us. Also, we thought on the concept of epistemic trust, which refers to, I'm quoting to Fonagy and Target, to the individual willingness to consider new knowledge from another person as trustworthy, generalizable, and relevant to the self. We think there is a subjacent question, which is, who should I know how to trust? After all, these families have gone through the caregivers in their childhood stories, now their sons and daughters, and also all the systemic violence they have gone through to get to the therapy. So I think it would be normal to these caregivers to have their barriers on constructing and developing this trust. And finally, we would like to share what comes next. As I said, this is a mixed methods study. So we are asking ourselves what is happening, for example, with the reflective function of these caregivers. How are they reflecting on their children's process and on their own process of this therapy? We are conducting qualitative analysis of the psychotherapy change process. And we're exploring also pathways of resilience, because this dose response is not written in stone. It doesn't mean that if you have 10 ACEs, you are going to have high PTSD symptoms. There could have been resilience pathways that we are exploring. And also, we're exploring how this intergenerational trauma is affecting the psychotherapy process. We presented some preliminary results in the Congress in Barcelona, of the Mentalization Congress in Barcelona, and we're also exploring barriers for mentalizing in this therapy. What could be making more difficult to these caregivers to have in mind their children and their process? So thank you very much for your time. Here is my email. If you have not received the paper, I will send it to you. And I will go to the discussion with Michelle and with Claudia.
Thanks, Nicolás. Very interesting presentation. So now, Michelle, if you want to ask questions or comments the presentation.
Yeah. So first of all, thank you so much, Nicolás and Claudia, for the wonderful presentation, but also the wonderful contribution to the field with this work. I think the study is incredibly interesting for lots of reasons, and the clinical implications are just sort of jumping out. So I'll make sure that we have a bit of time for the group here to ask some questions and make comments as well. So I have lots of thoughts and probably more questions than comments, but I thought I might sort of center it around summarizing and thinking together about the sort of key findings that you had. And Nicolás and Claudia, if you want to chip in and sort of comment. It's not a formal presentation that I've prepared at all, so yeah, let's have a discussion. So I guess that there's sort of three key findings that I drew from the paper. And the first one was the link between children who've experienced childhood sexual abuse and the probability that their parents have experienced high levels of adversity themselves in their childhood, and most notably childhood sexual abuse as well. And I guess that wasn't a surprising finding for you. It sort of confirms what many other studies have shown about the intergenerationality of the phenomena. But it does also raise questions of why and how. And I think that your study does go a little bit further to kind of helping us think that through. So that's the first sort of key finding. The second one, which I think is such a useful finding to hear about, is the link between the parents' ACEs and their alliance with the child's therapist, and what a big part that can play in how the child may benefit from the psychotherapy by being held in a supportive, parental kind of relationship that where the parent is able to also engage with the therapy, that where the parents themselves, well, first of all, where the parents haven't experienced adverse childhood experiences, that they're more able to do that, build that initial alliance, but where they have experienced their own difficult experiences, that might be a bit more tricky. And that has massive implications in terms of thinking about how we work with these children and their families in particular. So I thought that was a wonderful finding that has very sort of clear implications. And then the third finding, I've been trying to kind of figure out whether I was expecting it to go in that direction or not. And that's the fact that parents' PTSD moderates this relationship between their ACEs and their therapeutic alliance with the therapist. But my first reaction when I read the paper was, oh, okay. So low PTSD symptoms are associated with a stronger link between the ACEs and a poor engagement in the therapeutic alliance. But I guess, yeah, it sort of can go either way. So my question is, was it surprising to you guys, and did you did you expect that? Is that what you were sort of hypothesizing from the outset, or did it come from nowhere? Maybe I'll pause and let you comment there.
Thank you, Michelle. I was taking notes because the 3 points are very interesting and we could discuss a lot about that. First, I would like to talk about the why and how, what you said, the intergenerationality. And it's a question that's really drives me in a personal level, because before I started my research career, before the PhD, I was working as a coordinator of a community mental health program. And what drove me to the research was that most of these parents, because we had this logic of we received the children and we were paid by the government to give the therapy to the children. And we didn't have many resources to work with the parents too. But there was something there. Many of those parents, and I worked in a rural place here, it's like in the mountains in Chile, so the levels of poverty, the levels of neglect, of structural violence, these families had in their bags. And when we listen to these caregivers with these children with deficit disorder or behavior problems, that was just diagnosed that didn't recognize all of the trajectories of adversities of these families, it was like, there's something here that we could be doing more. And when we give the space to these families, to this, especially the mothers, because there's like also the parents, fathers didn't show up to therapy. I don't know if that's internationally, but the level of violence that these mothers have experienced in their childhood didn't have, in my experience, in my switch to the research career, was like the first time they discussed or shared that they were sexually abused, that they were receiving violence, was in the therapy of their children, because they as an adult didn't have an opportunity of pathway of resilience. So the how and why, there's many trajectories, right? But what drives me is the lack of spaces of healing and opportunities of recovery that these families have had the opportunity to receive. I don't know, Claudia, if you want to discuss a little about the how and why that Michelle was discussing.
Well, I wanted to go a bit further about this discussion, and that Denise also writes in the chat about how these centers that are related with child welfare are focused more on the parents' protection abilities, but don't focus on the parents' experiences, because as Nicolás has said, how the parents are parenting is related with their experiences as well. However, it's a very difficult aspect, because as always happens, resources are scarce, and usually the centers focus the resources on working with the children. But if you want to give the child a supportive environment, you need also to work with the parents, especially when they have these childhood traumatic experiences. So for us, it's also a big challenge how this research we can give new highlights for the public policy, because we think that this is a very big issue, and when we comment these results with the professionals that works in the centers, they think it was really important that research show this, because they struggle with this during their practice. How we work with the parents, but we don't have enough resources to work with them.
And I would like to complement that studies are showing us, giving us a glimpse of hope too, because yes, as Claudia said, we have so little resources, and the clinical social work, because remember, children are receiving psychotherapy, but these caregivers are receiving support from caregivers. But in Chile, we don't have yet a clinical social work approach. It's just developing here in our country, and I don't know in Latin America if it's the same. But what I like to hope is that recent meta-analysis and systematic reviews have shown that group works with parents, with ACEs, have shown good effects on their trajectories of parenting and in their symptoms. So maybe there could be some strategies that we could implement that are not so cost expensive. Yes, the training expensive, but there's hope too. And also, what I like to think in this how and why that Michelle said, I'm hopeful today, so I'm going to give a lot of hope to these presentations. But I like much what I said in this presentation in the background. What Karen Ensing has shown us, that a trauma reflective function can be a protective factor. So if we give this opportunity to the caregivers to reflect, to go back, to work with them, with their experience, can prevent another exposures. Because as we were saying, this is a mixed method study. And in the interviews, we have parents that their different children have been exposed to child sexual abuse, and they can't explain why. And this inability to explain themselves, it's not their fault. I think it's the fault of the systems that haven't provided these opportunities to stop, to care, and to think together. Let me go to the second question, Michelle. Okay, the needs. Yes. You discussed a little about these ongoing needs that we were observing in these caregivers. We have the needs of the children, right? But these results show that caregivers are living also a difficult moment. And what I think when you said that, I thought a lot of things. But now to complement, because maybe many people read the paper or already saw these results, I would like to go further into the preliminary qualitative results. And it's very interesting, because maybe we as professionals have the need to say we need to work with this parent's trauma. But sometimes, and in the caregivers discourses, interviews, they show us also that they have different needs that needs to be settled, like Maslow pyramids of needs. It's like, yeah, I was abused, my children was abused, but what I need now is my papers because I'm an undocumented migrant and I can't work. And if I can't work, I can't provide to my children. And so there's a lot of needs that it's very tricky to these professionals because they need to focus on one dimension, the protective skills that we were saying. But if we think in another level, it's like, can we protect if we feel unsafe? And if we feel unsafe in a very practical way, if I can't provide food for my children. So it's really interesting how we as professionals have our studies when we have our maps of theories, but what people have are different needs that we need to think together how we provide. I don't know, Claudia, if you want to say something about this.
No, just go further. So then we have some minutes for questions or comments from the audience, I think. And
the tricky, surprising question Michelle asked us about, was it a surprise? And yes, Michelle, it was a surprise because we had, when we hypothesized the moderations, we had like arrows, like for of thinking, like in our whiteboards. It was, okay, we think if ACEs are high and symptoms are high, we would expect that it moderates a lower alliance, but we found the opposite. So it was really like brainstorming and having all of our masters like Onagi and etc. with like, how can we make sense to this? And that's how we came up with the dissociation, like how they protect themselves because they experience threat. They are experienced threat. And I like this way that I sum it up, like two times it's too many times.
Yeah, I just, can I just make one comment on that? I think you had a couple of really similar thoughts to me in your interpretation of the results, that it's about sort of defenses, dissociative defenses that block out the capacity to think about how horrific the child's experience must be and how much they need help right now, and can engage with that because it will re-traumatize and bring back everything. So it's very defensively blocked out. I also wondered if it could also be to be very concrete about it, because you know, especially in light of what you were saying about how the type of help that these parents get, whether or not it's a more conscious, I'm not going to tell you how bad things are for me because that's going to increase the chance that you're going to remove my child. And so I'm going to hide how bad I feel about things. And I think whether it's a sort of unconscious, you know, blocking out of the experience, which I think is a very, and probably for many cases it is, and I think it's backed up by the research that shows this trauma-related reflective functioning it really plays a role in that. Or whether it's a more kind of just an idealizing, I'm not going to tell you how bad things are. Either way, I think it's a clue that there's a really important screening moment of finding out from the parent how they're feeling, because the PTSD questionnaire that you gave them was specifically about the child PTSD in relation to the child's sexual abuse. Is that right? So it's thinking about that moment.
Yes, when we apply this instrument, there's a part of the questions that's regarding to this experience, but it could be another kind of experience. So we broaden the questions. We try to focus it, but we broaden the question. And it's really interesting, Michelle, what you're saying, because that's what we are thinking about, barriers of mentalizing. making it harder to these parents to mind this process. So you said on the one hand could be dissociated, but also could be idealization, right? So what we've seen, just as preliminary, is that they have so many things in their minds, like they could remove the children, so yes, it could be different pathways of preventing this alliance, absolutely.
Yes, I want to add about that, about previous research we have done with qualitative interviews with parents of children who are in therapy due to sexual abuse. They talk a lot about this first part of therapy as a very difficult part of therapy because of these protectional issues. Because, as you said, Michelle, they are too scared of the consequences that this could have about what they are saying in therapy could have negative consequences, like removing their child from them. So they talk that this part of therapy, they are more reluctant. And when they start like building trust in the therapists, they feel more comfortable when they look that they are not removing the child from them. They can start engaging more like in the therapeutic issues and share more their experiences. So I think it's very important what you said, because probably it's also the context of these therapies, that there are therapies provided by centers that belong to child welfare. So it is a specific context.
And sorry, just one final comment. I mean, I can imagine in the context of a sort of discourse of you need to protect your child and you failed to protect your child, how that can activate in the parents their fight, flight, fearful response that there's danger around. And actually it can have a very the opposite effect, where their own attachment needs are so activated, and their fearful response to this dangerous situation of needing to protect their child, that it competes with their caregiving system, which is the capacity to provide that protection. And it's the more you kind of drill in the need to protect, because the world is dangerous and your child's in danger or has been in danger, I can imagine the more these defenses might come up as well.
And what's really interesting in these preliminary qualitative results is that this fearfulness that you said, Michelle, also expresses, I could say, like hatred to the therapist, because of how they feel excluded. Like in caregivers with high ACEs, we've seen that they make these comments like, I can remember some quotes, but the visceral feeling of being excluded from this relationship, how their experiences is being reenacted in this triadic relationship. So there's fearfulness on the one hand, there's exclusion on the other, and there's this therapist trying to do the best that they can with managing these both relationships.
Well, there are some comments and questions in the chat. I want to raise a couple of them. For example, Carla, well, thanks for the presentation. She says, now I keep thinking about the way in which it has been accompanied from protective competencies to parenting and the increase of dissociation. When the symptoms of PTSD go down, I have the doubt if from the trauma approach, the way in which they have accompanied these first therapy sessions are from a bottom-up or a bottom-down approach. Bottom-up or up-down approach. I also have the thought of whether they made any differentiation in the study depending on gender, because it is documented that women dissociate a much larger percentage than men. I don't know if someone wants to comment that. We have a lot of questions, so that's why I just comment one of them.
For the first question, I'm thinking on the longitudinal study that the interviews with the caregivers will give us answers or approaches to that answers regarding, for example, the objectives of the first sessions. This is what kind of interview we're using is psychotherapy change process interviews. So we are observing the objectives, expectations, the caregiver's trauma, the interventions they're receiving, and next year or 2 years, more like 2 years, we'll have those kind of answers. What these parents really received and how they experienced that, what helped and what hindered. And the second one, gender here in Chile, I don't know from where is the person that asked, but I think 98% of our sample is women. So there's also a gender bias here in who cares for children. And that's one of our things that we have in mental post-its of discussion for the future, how women have been imposed the roles of caring, and how can we support women in their role as women. Claudia?
Yes, of course. We haven't been able of doing that difference because we have like 90 or more percentage of the caregivers are women. Most of them mothers, but if not, grandmothers or aunts. And also someone asked for the therapist gender. We also have mainly women. It's more the percentage. I don't know, Nicolás, if you remember. It's more than in caregivers, but it's mostly women as well. Also here, there are some comments. For example, Carla talked about a freeze response in parents. Rosalind comment that there can also be a more conscious dynamic of prioritizing the child needs and minimizing their own needs. It could be as well. And I want like a last question about Denise's comment about the difficulties that therapists and social workers that work with these cases have between she said therapists and social workers are placed in a terrible dilemma between alliance and legal ethical issues concerning disclosing present abuse. Of course, in this paper, we don't comment much about therapist experiences, but of course, that is one of the issues that in the interviews therapists raise. I don't know, Michelle or Nicolás, if you want to comment a bit more about this.
Just from the qualitative interviews, therapists use a lot of, I don't know what's the word in English, but like investigation, like they are like investigation professionals rather than psychotherapists. So it's really interesting. Another study, as we're minding the barriers of mentalizing of these caregivers with their trauma in this therapy, what are the barriers of these therapists in mentalizing this process? Because they have this double role, like, am I a therapist or I'm a persecutor? I don't know.
Yes, and well, Esther asked about of the dyadic sessions. Well, in this case, we are analyzing what therapists do in their, common practice. However, now that we have a qualitative part and videotaping sessions, they use a lot dyadic caregiver child sessions. In the first part, more as an assessment, but we have to look how these continue and how they use them in another moments of therapy. I don't know, we are like mostly on in the time. I don't know, Michelle, if you want to add something before we end, or Nicolás.
Just to say a big thank you. It was a very interesting paper and yeah, very interesting discussion.
Thank you all for being here.
Yes, thanks to all of you being here, your comments, your interest, and well, as we said, this this session will be in the webpage, in our interest section webpage. So if you want to comment with others or share with others, there will be. So thanks to all of you, and see you in another session.
Bye-bye, thank you.
Bye, Sibel.